Good evening, everyone. Welcome to this ESCS free platform where we would like to discuss a very interesting paper. This paper results out of the selection of the ESCS literature research team, which has been working for years to present us the review of the literature regarding endocrine surgery. And I think this information is very important for those who do not know actually what this involves. What came out of this literature review this time is the paper, which is going to be presented by Henning Wolf from Schwarzwald by Klinikum Villingen, Germany. Henning, I thank you so much for being on this platform. I'm very happy that your paper has been chosen for to be discussed actually by our discussants, which is Cristina Martinez Santos from Malaga, Spain, Kerstin Lorenz from Halle, Germany, and hopefully Gianluca Donatini from Poitiers, France, but I think he won't make it because of an emergency situation. Autofluorescence is a hot topic in endocrine surgery, and your paper came out. We showed interest because it's a randomized clinical study. We really look forward for your sharings regarding the paper. And after your presentation, Kerstin and Christina will be there for discussing your paper. And afterwards, we will take the questions from the attendants. So there are not that much housekeeping rules, but for those who are attending this meeting, we're very thankful for having you on this platform. But for your questions, to have this platform also interactive, please use the Q&A button for your questions, and I will take care of them as good as possible. So Henning, once again, thank you so much, and we really look forward for your presentation and for your work. The floor is yours.
Thank you. So I hope you can see now my presentation. User, thank you very much again for your invitation, and thank you for giving me the opportunity to present my study here. As you all can see, we have dealt with the issue of near-infrared autofluorescence-based identification of parathyroid glands. This is no new topic. It has been broadly discussed during the last couple of years, sometimes controversially. And before I start with our study in particular, I will give you a brief introduction to this topic. Hypoparathyroidism is one of the major complications after bilateral thyroid procedures. It occurs temporarily in up to 40%. And it is sometimes connected with unpleasant complications, unpleasant symptoms to the patients with a prolonged medication, prolonged hospital stay. The reasons are usually a devascularization of the parathyroid glands during preparation of the thyroid, and damage or inadvertent removal with the thyroid specimen. The example on the right side is easy to recognize. It has the typical yellow brownish color. It is not hidden in a fat tissue, so you I guess you would identify this gland. But many of them are covered with fat tissue or covered with blood. So the aim is to detect them before to damage them. Near-infrared autofluorescence-based identification of parathyroid glands was introduced nearly a decade ago by a Vanderbilt University group, and they could show that parathyroid tissue has a much higher autofluorescence activity than the surrounding tissue when enlightened with near-infrared light. Nowadays, there are basically two systems on the market. Probe-based systems need direct contact to the suspect tissue, but these systems can nearly deliver a yes or no answer whether the suspect tissue is parathyroid tissue or not. On the other hand, image-based systems deliver an image of the whole surgical field. These systems enlighten the parathyroid glands, and they guide you to and around them to protect them. The aim of all these systems is to identify the parathyroid glands in an early stage of the operation and to prevent them from devascularization. We started with near-infrared autofluorescence in 2012 by receiving a prototype system of Karl Storz company. You can see that that system on the upper right image. It contains of a laparoscopic scope that is connected to a xenon light source that was originally built for ICG imaging and then added with additional filters to be suitable for autofluorescence imaging. This system also contained a large LCD screen and a foot pedal where the surgeon can switch between white light and autofluorescence mode during the operation. As a first step, we started with enlightening parathyroid adenomas, as you can see on the right side. So we gained experience with the system, but very quickly asked ourselves the question whether this system would be useful to reduce the incidence of postoperative hypoparathyroidism after bilateral thyroid procedures. To answer that question, we designed this study with two study arms. In the control group, patients underwent conventional thyroidectomy with visual identification of the parathyroid glands and preparation of the thyroid, as you all would do that, and an intervention group where the identification of parathyroid glands was supported by near-infrared autofluorescence. How we did that, we'll explain later. When we started this trial, the effect of the system was not known, so we assumed a 25% reduction of the incidence of a postoperative hypoparathyroidism, and we used our own incidence of 28% as a reference incidence. So the sample size was calculated 30 versus 30. The patients were blinded in this study, and the randomization was on with a software and performed directly before skin incision. The inclusion criteria were bilateral thyroid procedures for benign thyroid diseases, so malignancies were excluded, as well as known primary or secondary hyperparathyroidism. We also excluded prior thyroid operations. As the primary endpoint, we defined the incidence of hypoparathyroidism at skin closure to keep it away from outer factors as medication. As secondary endpoints, we used the calcium reduction, the number of parathyroid glands identified, the length of the hospital stay, the medication administered, and the symptoms that were associated with hypocalcemia. Here you can see a timeline of the participating patients. They all were randomized prior to skin incision and all got the first parathyroid hormone and calcium measurement directly before skin incision. The patients from the control group then underwent regular thyroidectomy with the visual identification of the glands. And then after finishing the thyroidectomy, a second PTH was then measured directly after skin closure. In the intervention group, the thyroid lobe or every lobe was mobilized and the upper pole vessels were ligated and the lobe was medialized. Then we darkened the operating room and then enlightened the surgical field. We then noted the shining parathyroid glands and then continued the preparation of the thyroid along the thyroid capsule. When we found another structure that was a parathyroid gland in our eyes, we then repeated autofluorescence to decide whether this structure was fluorescent or not. As a reference structure, we used a Vicryl suture because this suture showed a autofluorescence activity that was similar to parathyroid glands. The patients in the intervention group then got a second parathyroid measuring at the end of the operation, and this measurement was in all patients repeated on the morning of the first post-operative day in combination with calcium, and a second calcium measurement on the morning of the second post-operative day. The pathologists scanned our specimen for inadvertently resected parathyroid glands, and the patients were asked twice a day about hypocalcemia-associated symptoms. The two groups were equal in terms of gender and age and thyroid volume, but there were significantly more patients with a diagnosis of Graves' disease in the intervention group. We did not perform a subgroup analysis because of the low number of patients in that group. As you can see down here, there were 6 surgeons participating in the study, and these surgeons were not randomized to the two groups because we wanted to keep the study as simple as possible and to keep it working in our routine, our surgical routine every day. The operation time was about 4 minutes longer in the intervention group, and that was the time we had to use to darken the operating room and to use autofluorescence, but that was not significant. The number of parathyroid glands identified was equal in both groups. It's 3 glands per operation, but there were slightly less patients with none or just 1 identified gland in the intervention group. But then the parathyroid glands autotransplanted per gland were less in the intervention group than in the control group, but that did not reach significance. We just resected 1 gland inadvertently in both groups. When we look at the lab results, there was no difference in the absolute calcium and absolute parathyroid hormone reduction from preoperative values to postoperative day 1 or 2 values, but a trend towards a less calcium reduction from pre-incision to postoperative day in the intervention group. but this did also not reach significance. Concerning the primary endpoint of this study, there was a clear trend towards a lower incidence of hypoparathyroidism at skin closure, but we unfortunately missed significance at that point of time. When we look at the postoperative day 1 and the incidence of hypocalcemia, the symptoms, and the medication, as well as the hospitalization length, there was no difference between these two groups. What could be the reasons for that? One, or let's say the key issue of this technique is the tissue penetrance. Because the goal of the systems is to identify the glands in an early stage of the operation when the parathyroid glands are usually covered with fat tissue or blood. And the key is also to preserve these glands by identify them in this early stage of the operation. Nowadays, systems are reported to have an tissue penetrance of a few millimeters, but we experienced in our system a penetrance of just 1 or 2 millimeters. And that could be modified by additional filters. This could be modified by modified wavelength, but we did not change the system during the study to keep the results and to keep the groups comparable. This leads to the second point. I call it decision making. We experienced a lot of glands to have a weak autofluorescence signal, so the system was not helpful in finding them and was not helpful in deciding whether a structure was autofluorescent or not, and whether it was a parathyroid gland or not. And that was even worse when there was light in the OR. When there was light from the outside, we unfortunately do have windows that cannot be completely darkened, and this changed the autofluorescence signal. It weakened the signal, as well as the different the distance of the scope between the scope and the tissue. We also experienced a very flat learning curve, because with these changing conditions, it was not easy to learn what structure and what autofluorescence signal is enough autofluorescence to decide whether a structure is a parathyroid gland or not. The second point is the repentation rate. We measured a repentation rate of 27% per operation in the intervention group and about 37% in the control group. And this is more than twice as high as our regular repentation rate of 14% per operation. And I can only explain that by the observer effect. The surgeons were not blinded in this study, and they probably tried to be as good as possible, or they were not sure about the vascularization of the glands, so they tended to retransplant these glands more than they usually would do that. The last point is the sample size. One can guess that this assumed reduction of 25% might be a bit overestimated, and that led to this low sizes in both groups. So with a reduction of probably 20%, there would be a higher sample size in both groups, and we probably have reached then significance. To sum it up, this study has some limitations. This study design was single-blinded, so the surgeons did have an observer effect. We did not perform a follow-up in this trial. We did use a technical system that was a prototype system that was not originally built for autofluorescence imaging, but for ICG imaging. And we did have a small sample size. What were the pros and the cons of the system? In our opinion, it was easy to handle, and the attending inexperienced surgeons told us that they very quickly learned how the parasite glands look like and how to identify them. And they told us that the system helped them with that. The cons are that, in our opinion, the identification of the glands in a very early stage of the operation does not prevent the glands from being damaged during the following preparation of the thyroid gland. And the system we use was more a confirmation rather than an identification tool, but that directly leads to the factor of tissue penetrance. And the system did not give any information about the vascularization of the gland, so we could not decide whether to retransplant the gland or not. And that could be improved with ICG. There are commercial systems that combine ICG with autofluorescence, and these systems help you to decide whether to retransplant a gland or not. Thank you very much.
Thank you very much, Henning, for this excellent presentation. Thank you for being on time. And we already have received a question from Yemen, and you already have answered that. So for those who raised up their hands during this presentation, please use the Q&A button for your questions. And we will have some time to take your questions from the floor. But first, I want to invite our discussants, Kerstin Lorenz, Cristina Martinez Santos, and Gianluca Donatini, who has finished his emergent issue. Thank you for being on the platform, Gianluca. Kerstin, shall we start with you to discuss this paper?
Sure. Well, first of all, thank you, Henning. It was, I think the study design is really nice. I like that you had these two groups built. Can you maybe enhance on how you try to first identify the parathyroids in the control group, and how far you would try to dissect before you would first use the autofluorescence camera? Because I think in your study design, you try to make a point that first and early on identification rate between the two groups.
So I think the idea of the system is to identify the glands as early as possible. And that's why we enlightened the surgical field after mobilization of the glands, when you would usually see the glands for the first time, if they are visible. And
so how far would you mobilize before you would first try to look for parathyroids?
I would mobilize the upper lobe and then rotate the gland, the thyroid medially, and then I would use the system first.
Okay, that's after, say, taking the upper pole vessels, right?
Yes.
Oh, okay. So you start on the upper pole, then you mobilize it, and then you try to expose it. Would you do it likewise when you do it without the fluorescence machine? Would be the
Yes.
same
Yes.
procedure?
Yes. Yes.
Okay. Okay. Second question I have is, how did you find the ability to differentiate with false positives.
So as lymph nodes or a thyroid tissue, we
All
did, yeah.
colloid nodules are usually the ones that are difficult to differentiate between capsular parathyroids versus colloid nodules.
So the system we used, you're right, was weak in these nodules. They also sometimes showed a high autofluorescence signal. And when there was too much blood, this also showed, I don't know why, autofluorescence signal. But I think with the systems on the market, that should be better than with our system.
Okay, just one last question regarding, you said that you were a bit disappointed that the identification was not better than you had probably hoped for. Did you, well, what was the main point? Because I don't think that the depths of the tissue should be an issue, because then most of these parathyroids would be intracapsular or intrathyroidal. Did you not find it maybe an effect of the angle that you could use to apply the camera towards the parathyroid you were trying to identify?
Of the angle of the scope to the tissue.
Yes.
Yes, it is of the angle was best in 90 degrees, of course, and the distance was about 3 to 4 centimeters with the system, but this could be different in another system.
Okay. Well, thank you. I think we should
Thank you.
have someone else to ask questions as well. Thank you.
Yes, thank you so much, Kirsten. And now we jump over to Christina. Christina, are you ready for your questions to discuss with Henning?
Okay, good afternoon, everyone. Thanks, Henning, for being with us today, analyzing the results of your study. And as you explained in the article, the participating 6 surgeons were not randomized into groups. Do you know the rate of hypocalcemia and hypoparathyroidism associated with each surgeon before starting the study, just to get an idea of the differences between surgeons? Did you analyze in this study just the results of surgeon 1, because it's the person who operated most of the cases in both groups?
Unfortunately, we did not check these results before the study, and we did not perform a per surgeon analysis of the operations. Now we did not do that. It would be interesting, yes.
Okay, and according to the paper, patients were routinely discharged at least on postoperative day 3. Is this your usual protocol, or is just for the study? Because apart from this study, did you give earlier charges when PTH was higher than 12 or 15? Because one of the secondary points of your study was the length of the hospital stay. And if you keep patients 3 days routinely, maybe you cannot find differences between 2 groups.
Yes, you're right. At that point of time, this was a routine, a point of discharge at the morning of postoperative day 3. We've changed that nowadays to day 2. That is, it is because of payment restrictions of the insurance companies. They do not allow us to do surgery to discharge them on the first day or ambulant, but this was the usual protocol at that time. Yes.
Okay, and just my last question. You talk about the higher parathyroid replantation rate between 27 and 37%. Is higher than in previous series, as you explained. And you think you could be a consequence of the observer effect. I understand the argument for the intervention group, due to the system's low tissue penetrance, but I don't understand for the control group. Do you think that in the control total thyroidectomy was performed not according to standard practice, perhaps because the surgeons felt it was a competition between two groups or something like that?
Yes, I can only explain that this way. Because the operation was exactly performed in both groups. The surgeons were the same in both groups. So I don't have a good answer for that. Other than there was a race for a good result of the study, especially in the control group. And I think that the surgeons were probably not sure about the vascularization, and they transplanted more than they usually would do that.
Okay, thanks. It's all for me just now.
Thank you.
Thank you.
Okay, thank you so much, Christina. Now we move over to Gianluca. Gianluca, welcome
Hi.
to our platform. You also
Thank you
have
very
some
much.
experience regarding autofluorescence, and I know you show interest to this paper of Henning. So I'm sure you have also good questions.
Yes, thank you very much to have me invited as a discussant. Thank you, Henning, for the paper. I really enjoyed reading your paper. And I have few questions. Once actually was overlapped by Christina, so I will not ask you about the transplantation rate. Or maybe I will do some a small comment. But it was just my curiosity why you test at skin closure and on postoperative day one. Why don't you test little later, like 4 hour post, or it's take much more than after total thyroidectomy to skin closure? You still have 30 minutes so you can manage properly.
Mm-hmm. We tried to find a point where the influence of, for example, medication was as low as possible, and that's why we chose this point of skin closure. And it's always the exact same at time point. Yes.
It was arbitrarily taken. Okay.
Yes.
So just a little comment about the sentence in which you state about the navigation system with autofluorescence. I actually started with the same kind of dissection, saying that I will confirm that I've seen parathyroid glands with a probe, but soon after acquiring experience about this, nowadays I actually going directly with the probe, and I'm not searching anymore by direct vision the parathyroid glands, and I do actually the contrary. I confirm by direct vision which is the parathyroid glands, because sometimes, especially in patient with there's a lot of brown fat tissue, you are quite in difficulty. And I would say that I do the same that you do. I mobilize the superior pole first. I'm not cutting all the superior pole. I'm just doing the anterior part and not touching the posterior, which harbors sometimes vessels for the superior parathyroid glands. So maybe it will be much more necessity of time, because the number of patients and the number of surgeons is very limited, so you cannot acquire the proper learning curve, which usually it's around 20 to 30 cases before managing correctly the probe. So I would like to know if in between the time you wrote the paper and now, if something changing about your navigation, or if it stands still in the same position.
So the system we used for this study is not in use anymore.
Okay.
It was just a prototype, and we said for us, okay, this system does not help us, so we will not use it anymore. And I unfortunately do not have one of the newer systems. So in that way, I cannot answer this question to you. But I do have the question to you. If you enlighten the surgical field, do you always see the glands shining through the fat tissue, especially on the lower pole?
I find better on the inferior pole, because sometimes it can be in the thymic horn, so you can just dissect the capsule of the thymus if you are missing. The superior, sometimes I cannot see, especially if they are deeper and posterior to the lobe. So sometimes you miss that. The things that with the probe I use, sometimes thyroid autofluorescence can be high. I still do not have the answer why sometimes thyroid are really, I would say, homogeneously autofluorescent, because a colloid nodule can be autofluorescent, but sometimes parenchyma of thyroid is quite fluorescent, and I don't have the answer. Maybe Kerstin has it, but I think that it's easier to go to the inferior one than the superior one, which are much more ectopic in anatomy. And for the system, I guess that your limitation actually came from a probe which was not designed to autofluorescent, but it was designed to ECG. That's why I choose one probe instead of another, because I had a probe which was designed in evaluation for ICG. It was 4K images. It was 3 different color images. It was astonishing in quality of image, but the sensibility for fluorescence was lower than the system that I currently use. And my last comment, yes, about reimplantation and hypoparathyroidism, it's always the same. My game changed when I start using ICG, because with autofluorescence, I reduce a little bit, but not that much, postoperative hypoparathyroidism. But with ICG, it actually went down vertically. And I guess that ECG will be useful to avoid unuseful transplantation, because sometimes you can have darker parathyroid glands which are still vascularized. So maybe with ICG, you can see that there are some inflow and some outflow. And what I've seen also with ICG, when you have a parathyroid hematoma, you can just do the incision on the capsule, and you can see actually the ICG flow which start to come inside. So I think ICG associated, it's a very important technique. It's like it's not the good comparison, but I think it's like when you use continuous monitoring and intermittent monitoring. Intermittent monitoring is very nice, but continuous can give you some little details which change the whole job.
This is a good point. These systems give you 2 answers to 2 questions. Autofluorescence itself answers the questions where the glands are, anatomical questions, and ICG answers the question whether the glands are vascularized or not. So to retransplant them or not. 2 questions and one technique. So
yeah, I guess it's like if you want to go in a mining field, you want to know where mines are. So with ICG, you know.
Yeah.
Okay, thank you so much, Gianluca, for your questions and comments. It was very fruitful, if you ask me. Now I'd like to jump over to the questions from the platform. Tonight we had reached nearly 80 attendants from 2 continents, Europe and Asia. And actually, one of them has been answered. And the other one, I would like to ask you once again, do you think that surgeon's experience can affect the results?
So all the 6 surgeons did the operation in nearly the same manner, with the same technique, the same preparation steps. So I think the influence of the results was very low
Mhm.
with the 6 surgeons.
Okay, thank you. And another question is regarding the age. Is there any age limitation for using the this system?
No, there should be no age limitation. No,
No age
absolutely not. No.
Okay. For the discussants, do you have any comment regarding this? Is there any age limitation for using the NIRAF or during the operation? Sorry. Yes, Kirsten.
Well, there's no limit in applicability. However, we know that it's not very useful in the pediatric population because they don't show up with the autofluorescence till, say, the age about 10 to 12 years, then it starts picking up. But earlier than that, it's disappointingly very low. Could still
Thank
use
you
it,
so
but
much.
it's not very helpful.
I could confirm.
Yes,
I
yeah,
don't know if it's associated with sex hormone when they kick in, maybe.
Mhm.
But
No,
I
it's
don't
no
know.
gender difference in our
Yeah.
results so far.
No, I mean when differentiation with testosterone and estrogen progesterone comes, so they get fluorescence, but we do not know the
No,
fluorophore.
we do not know.
Not
But
yet.
I would say no, because from experience, the girls are usually a bit earlier than the male population, and we don't see any difference in girls and boys at that age.
Mhm.
It was very important, I think, to underline this. Thank you so much for bringing this up. Two final questions. One is about the sample size calculation. Was a sample size calculation adequate to demonstrate the significance? Do you have any comment regarding this?
As I said, we just assumed a reduction of 25%, not to know the effect of the technique in 2014, a lot of time ago. And when we calculated that sample size, it was 32 versus 32, and we asked our statisticians, and they said do 30 versus 30, and from the nowadays perspective, it was overestimated, this 25% reduction.
Okay, thank you. And the final question from Switzerland. It's an interesting fact that the younger surgeons seem to profit from the system, learning to identify the glands. Did the system train them to identify the glands now earlier without the system?
They told me that they did. Yes, they asked more themselves about the position of the glands and how the glands looked, and what is a parathyroid gland or not. So they concentrated more on the glands than before, but that could be an effect of the study itself. But
Okay.
I think the system helps in training them. Yes.
Kirsten, I think you have something to tell.
No, I was just wondering, with this regard, is that effect holding on now that you don't have a system right now?
Yes.
Were they able to sustain the effect of earlier and maybe more confident identification of the parathyroids?
So with a large number of surgeons that participate these operations, it hard to answer their questions. But when we gave away this system, yeah, the concentration for the glands was still that high.
Can I still have one more question? I was a bit surprised at the very low number of unintentionally resected parathyroids in your specimen. I mean, that's, of course, you are to be congratulated to this, but in our experience, we weren't that successful in really trying to have no parathyroid cell identified by the pathologist, even though we do routinely assess every specimen that we send off by fluorescence technique. And do you have any clue why there's no difference in your specimen with or without the machine?
This is a good point. I hope that the quality of the specimen analysis was good for both groups. It's the in-house pathologists, and you can ask whether the pathologists did not specifically search for the parathyroid glands. But I don't have an answer. As I'm not sure if why there was just one gland resected.
Okay, Henning, thank you so much. I think we have come to an end. There are no other questions from the participants as well. I'm very happy with having you on our platform for sharing your paper, for sharing all the details, and for taking the questions very honestly. And thank you for being on our platform tonight. And I would like to thank our discussants, Kerstin, Christina, Gianluca, for being on this platform tonight. And I'd like to thank the participants. I already mentioned tonight we reached around 80 from a lot of countries. And thank you. Thank you for the interactive question and answers. Participation, and of course Christine from Vienna office for the technical support tonight. And finally, I would like to invite all those who are here to stay tuned on what's going on the ESES platform, which is running very actively. And I would encourage them to be a member of the ESES platform. And as you have seen, especially for the young ones who are planning to attend the UEMS board exam, that this is serves like an educational platform also for the UEMS DES exam. So possibly we are going to put these, we discussed this with Kerstin as well beforehand, to put these recordings into the banner, which is on the website of the ESES. So stay tuned all. And once again, I thank you very much for being on the platform. And for the rest of the evening, I wish you all a pleasant, peaceful evening. Bye-bye.
Thank you very much.
Thank you.
Pleasure.
Bye-bye.
Very much, Jose.
Bye.
Bye, Christina.
Bye.
Bye, Christina. Bye.
Thank you.
Bye,
Goodbye.
Henning. Bye.